Welcome back. Good morning, Richard. It's good to see
Good
you.
morning, morning. How are you?
I am doing well.
I
Uh,
heard something.
yeah,
I heard that you and I were both out last night on a Friday night.
you know,
How often does that happen?
not very often.
Man, I
But
was shocked.
what's really strange is we were at the same event, but never saw each other. We texted each other like, "I'm here," and then you came
I'd
to.
get there and say, no,
And
you aren't.
so yeah, it was First Friday, and they have a little thing downtown here in our small town that we live in, and it was great.
Yep.
So yeah,
First Friday of October.
yes,
So here we are, barreling into the holiday season. For
absolutely.
those of you who do holidays, I wanted to mention it's also a very stressful time of year. So we may revisit that topic of stress sometime between now and the end of the year, now or the end of January when we have to pay all the bills.
Absolutely.
Um, so we may drag that topic out again before we finish with the holidays.
Absolutely. Because we're not going to talk about that today because we're
Right.
going to talk about another thing that you and we have talked about this topic for a long time,
I know.
actually. I can remember back in the, what would they call them, the early aughts, the like 2012. Oh no, these would be like the teens, like
Right.
2012, 2010. We started working with what at that time was called early onset bipolar disorder, but it was bipolar disorder in children.
Right.
And
Mhm.
so there was an interesting article in that were posted in the show notes from Slate
Right.
that kind of brought this topic back up again. And so we thought that, you know what, it's time for us to talk about it a little bit more.
Right. In the business, you see this diagnosis over and over and over again, and you keep thinking, could that many people? Is it really bipolar disorder? I mean, that's what prompted this. And we've talked about that many times. Um, and so when I saw this article and they talk about bipolar disorder, is it being overdiagnosed? And I thought, well, I think it is. Let me look at this article and see what he has to say about it. It's from Slate magazine, and they begin with, and Bernie, I remember. You saw a family, my goodness, it must have been, I don't know, 12 or 15 years ago.
You know,
You
you
know what I'm talking about.
You know what? But let me say this first, because we're talking about 2012, 2000,
Right.
around the teens. It was
Mhm.
actually before that, because remember, 2013 is when DSM-5 came out, and
That's correct.
DSM-5 changed the title of it. So it was in the aughts, from
That's
between
right.
2000 and
It was
2010.
before DSM-5 came out.
Yeah.
And in fact, I think we put it in the introduction of our book, this young woman you had seen. And it made me think of this person. This article begins with a discussion of a young girl. I think she was about 15 or 16. She was diagnosed with bipolar disorder at age 10. And so by age 11, so she's diagnosed at 9 or 10. By age 11, she had been prescribed Zoloft, Concerta, Celexa, Lexapro, Risperidone, Neurontin, Depakote, Seroquel, Lithium, Topamax, Trileptal, Abilify, and Adderall.
No, not all at the same time,
No, at
just over the
various
course of a year.
times, you
Yeah.
know, so obviously they're just throwing medication at, we don't know what symptoms this girl had, but based on the medications, she's had some kind of a mood disorder and some ADHD type things. She never did get therapeutic effects, but she got a lot of side effects, which were sleepiness and tremors and body pain. She was always sort of had a mental fog. She remained very moody and had emotional outbursts. So whatever this young girl had wasn't being successfully treated despite all these efforts. And I'm sure there were well-meaning professionals who were trying to find something that would reduce her symptoms, but they never did. And they go on to tell the story later on. What bothers, then they go on to talk about the increased incidence of bipolar disorder, the increased diagnosis.
Yeah.
And this occurred, and these are very important dates, and we're going to get into it later in the podcast. From 1994, and I always use 1995, but this article is 1994 to 2003, the the diagnosis doubled in adults in a 10-year period. There was a twofold increase, so it doubled in that time period. That's pretty unusual
Yeah.
for any diagnosis. And so you say, well, what was the real reason? It wasn't because more people had it,
Right.
but there was some other reason for it. And then the article gets into what they believe are the problems. And as we look through these, as you and I look through this list of problems, we say, oh yeah, this is the stuff that we've been talking about.
Right.
Okay?
Absolutely. Because it went from, relatively not, I wouldn't say rare, but something that wasn't
It
quite
was
as
single digit percentages, right? I mean,
absolutely.
2 or 3%,
And all of a sudden, millions of people are being diagnosed with bipolar disorder. And so we have this phenomenon of what we just call false positives, and that's where, a person is diagnosed with something, or a person is said to have something, but they don't really have it. And I know that I have experienced that, and I know that you have as well, where we will see patients who come in with a diagnosis of something like bipolar disorder, but bipolar disorder is a good example of frequently come in with that diagnosis, and after meeting with the person for just a little bit, it's like, I don't really think that that's what's happening. I don't think that that's what's going on. We don't really have the criteria that's met the way that it's outlined, but
right.
have this problem of false positives, and it's really significantly increased the number of people with this diagnosis.
Yeah, and as it turns out, there was a study in the Journal of Clinical Psychiatry, which is a reputable journal. This was in 2008,
Mhm.
so during the same period. And what they did is they took a cohort of patients who had been diagnosed, who have a diagnosis of bipolar disorder. They reevaluated them and did a whole series of tests, very careful analysis, and found that I think about half of them, about half of the patients with the diagnosis really didn't meet criteria. They had been misdiagnosed.
Okay.
So they have been given a diagnosis that they shouldn't have had. And that's what a false positive is. There's also a false negative where you
Right.
miss the diagnosis, you don't think they have it, and they do. So there's also a false negative. But the problem with bipolar disorder, one of the problems, the first one, is this high rate of false positives, people getting a
Absolutely.
diagnosis who shouldn't.
Right. And then that kind of brings us very nicely to this issue of pediatric bipolar disorder, or what we used to call early onset bipolar disorder. And that's and we used to do a lot of work with kids who had this diagnosis. In fact, in our area here, we
Mhm.
typically had many of the referrals from psychiatrists and other clinicians. Whenever a child was diagnosed with early onset bipolar disorder, we would see
Right.
those kids and families. And um, we were always troubled with this issue of they were receiving the diagnosis. And at the time, it was the best that we had. It was before the DSM-5 came out, and they kind of worked on some things with the diagnostic. Uh,
Mhm.
but they didn't really meet the criteria for traditional bipolar disorder, but yet they were receiving the diagnosis of bipolar disorder nonetheless.
Right. And I think I think we know why that happened. And we're going to talk about that in the last problem, because
Yeah.
I think it's an insurance problem. I don't think it's a diagnostic problem, not a mental health problem. I think
Right.
it's an insurance problem. But you're right. The problem with bipolar disorder in children is that, first of all, the diagnosis was not meant for children.
Right.
Nobody intended for this to be used in children. And second, the symptoms in children are vastly different than the symptoms in adults. And despite all of that, despite those two cautions, the number of children diagnosed with bipolar disorder dramatically increased in the middle 90s. Okay. And this leads us to the third problem, because we have the first problem, which is more adults are getting the diagnosis who perhaps shouldn't have it. Many children are getting the diagnosis who perhaps shouldn't have it. And the third problem is misdiagnosis,
Right.
because if you're making the wrong diagnosis, there's there's the other side of that coin is you're missing the correct diagnosis.
Right. And so, we've talked many times, especially recently, about this idea of, people going onto Google and getting a diagnosis. And we've certainly had, I remember back in the early aughts, when we were first kind of working through a lot of this, there, there was a book that was
Oh,
published called, it was just referred to early onset bipolar disorder. I think was just the name of it.
it was called, I think, The Bipolar Child.
Oh, you know what? I think you're right. And it was a good 2-inch thick book.
It was a, yeah, yeah.
And it was, there was a lot of really good information in it. But
Mhm.
the really concerning thing, and I think what's relevant to what we're talking about here is that we always reference these 2 pages.
Right.
That, it said, here are some common symptoms, typically seen in children with bipolar disorder. And my goodness, this list included just about everything that a child could possibly do.
Right.
Um,
That was everybody's reaction.
right.
Like, who doesn't qualify?
It was things like, certainly it was things like, overreacts to things, is very emotional and things like that. Okay, those things make sense for the diagnosis. But then it was things like prefers sweets, um, and, likes to eat candy and, has a hard time going to sleep at night. And you start thinking that we are talking about, the vast majority of kids here. And so we would have parents just coming in because these kinds of lists would be posted on the internet, and so parents would just be flooding in with these concerns that their kid has
Right.
bipolar disorder because
Mhm.
we were looking at this list of possible common symptoms, and my kid has a bunch of them. And I was
Right.
like, so do I. I like candy a lot too. So
Right. Yeah. And that was everybody's reaction when they saw those 2 pages. It was like, my goodness, who isn't like this? I mean,
right,
and so, and that became the Bible for about 10 years. It was in
right,
it had 2 editions within about a 5 or 6 year period. Very popular book. But you're right, there was a lot of good information in that book, but it left you with the feeling that I'm not sure who has this and who
right,
doesn't. So misdiagnosis is the third problem. And the problem with that is, does the person have this diagnosis and are we missing the correct diagnosis? And that's what worries me. And because the problem with bipolar disorder, as with many other mental health conditions, is the symptoms of bipolar disorder overlap with the symptoms of many other disorders. And you have to be very, very careful um, about the overlapping symptoms and making sure you get it right. One of the authors of that study that we cited a few minutes ago, when he was a resident, he would get in trouble because he took too long to interview each patient.
right,
And when he was a resident, they kept saying, no, you don't have a half hour. You don't have an hour to talk to one patient. You have to do it within 50. It's part of your training in medical school is you have to do this within 15 minutes. And he said, no, I'm going to take a thorough history.
mhm,
And now, after he finished his degree, he went back and did the research and said, it takes more than 15 minutes to get to the right diagnosis. You can't just give somebody medicine based on a 15 or 20, 10 or 15-minute interview.
right.
You got to get the diagnosis right. The fourth problem
Well,
is one that I know.
I want to throw in something else in there
Yeah.
real quick. In that, and because this is another issue that you and I see very often, is that, yeah, you want to make sure that you get the diagnosis right. I think what even comes before that is you have to make sure that the person even has a diagnosis. So often, we see kids and the parents come in and they have this concern and that concern. And again, they're talking about things that are sort of common, typical childhood things that the kid's going through.
Right.
Or, my kid feels really depressed and they're always crying. And so you ask a couple of questions and all of a sudden you find out, well, dad was deployed and, their grandparent passed away or something. And it's like, well, of course they're sad and
Right.
distressed.
Mhm.
Their whole life is changing right now. And so we even have to make sure that the person even has a diagnosis because
Mhm. Mhm.
sometimes it's just normal life.
It's life.
Or
That's right. It's not a diagnosis. It's life leaning
right,
against you. Right. Now, this, I know you did, I think you did a lot of this stuff when you worked with Dr. Silver
Mhm.
at USF in the medical school. Um, there's been a loosening of criteria, diagnostic criteria. As most of you know, when we make a diagnosis, we look at the criteria for that diagnosis. What are the symptoms? What does a person display that we say, well, all those things equal this diagnosis? Okay. But if you loosen the criteria, it gets more and more difficult to make an accurate diagnosis. For example, um, until 2013, we had this diagnosis of autism, and it was called pervasive developmental delay, PDD. And within that category, there were five distinct diagnoses: autism, Asperger's, and a couple others. And it was fairly easy to say that, well, this person has Asperger's, but this person has autism because there were criteria for each disorder. In 2013, autism, all those categories were done away with. And you have one category, but the
Autism
symptoms are mild to severe.
right.
And it has become a little more difficult to say, to make that diagnosis, but it's especially difficult to avoid false positives
Right.
because the criteria have become so broad that it's easy to make that mistake of a false positive.
Right.
And this happened with bipolar disorder because this diagnosis first appeared in 1851. Somebody in France named it bipolar disorder. It first appeared in our medical literature in 1980, the concept of bipolar disorder. And from 1980 to 1994, we have this idea of manic depressive, and then in 1994 we call it bipolar disorder. But in now we have a bipolar disorder 1 and a bipolar disorder 2.
Right.
And
And then as well as cyclothymic.
cycling. Okay. So what has happened, and remember what we're looking for is why has there been such an increase? Well, if you loosen the criteria,
Mhm.
which is what happened with autism, if you loosen the criteria, more people are going to fall into that category.
Right.
Bipolar disorder, the classic manic depressive disorder, first identified in 1851, first put in our manuals in 1980. Then in 1994, we had bipolar disorder 2. I refer to it as bipolar disorder light. It's sort of, but not quite. Instead of a week of mania, it's 4 or 5 days of mania. Well, then we went from maybe possibly mild bipolar disorder to subclinical. Well, you have symptoms, but you don't have it. To now, we're talking about a spectrum,
Mhm.
that from mild to severe bipolar disorder. A lot of people get dumped into that pot.
Right.
Okay. And there's a lot of false positives.
Right. But yet oftentimes people, even clinicians, will refer to it with the broad heading of bipolar disorder. And so you have somebody who is on the extremely mild end of, maybe some mood dysregulation.
Mhm.
And because they get irritable sometimes and they don't quite meet the diagnostic criteria, so they're on that very mild, bipolar disorder not otherwise specified type of
Right.
thing. And but then they put it under that same broad umbrella of, oh, they have bipolar disorder, and so
Right.
significantly boosts the numbers.
Right. So that's another problem, that when you loosen the criteria, and adding bipolar 2 really loosened the criteria. So you try to keep these very strict criteria to say the manic episode has to last at least this long. You're not manic for a day or two. You're manic for, it has to be a week, right? For bipolar 1. Bipolar 2, it's fewer days. All
Right.
right. But
I,
then, um,
well, but I think that the other part of that is another thing that loosened it is, as you look at the criteria, even with mania, it has to be a week. But then there's a little caveat that's added. It says that unless hospitalized and stabilized in the hospital. Well, if a person is really agitated, really angry, and upset about something, it is, and I hate to say it in this way that makes it seem like we're minimizing it, but really not trying to minimize it, and because we think it's a huge problem. It doesn't take much for a person to get Baker acted. In Florida, it's called a Baker Act. It's when you're involuntarily hospitalized because of psychiatric or mental health conditions. People are worried that you're a danger to yourself or others. It is not in any way difficult to be Baker acted in Florida, especially in our area. You know, if
Takes
people
a phone call to the police.
just absolutely. And so, you know, again, if later on in life you're talking to a clinician and they say, yeah, well, there was this one time that I was really upset. I was kind of agitated and upset, and I got Baker acted. And, you know, I was in the hospital for a few days and I was able to calm down, and then I was able to go home. Well, you know, depending on how the clinician looks at it and talks to the person about it, sure, yeah. So that is, you know, maybe you were in a manic episode and you had to be hospitalized and you were stabilized in the hospital, and so maybe that counts as a manic episode, and that's all you need to meet criteria for bipolar disorder type 1.
That's right. Or somebody comes in and you know you're giving your history and you say, well, I'm sad, but then some days I'm real happy but then I get depressed again. Well, many of us could tell that same story. It doesn't mean you have bipolar disorder. Okay, so we have to be very, very careful with this diagnosis. Now, the last problem that we want to talk about are the insurance companies, and not as a group. I mean, we're not talking, you know, criticizing insurance companies, but here's what happened. And this goes back to pediatric bipolar disorder.
Mhm.
In the middle 90s, we didn't make this diagnosis in children. And I said earlier that the symptoms are different in children than they are in adults. Children typically don't have a 1 week manic episode, all right, or a 4 day manic episode. They have a temper tantrum that might last several minutes to several hours, and then they recover and go on about their lives. And there are lots of kids who do that. They have these explosive outbursts. And until 1995, and you remember when we were talking about those dates from 1994 to 2003, we had this gigantic increase. In 1995, we weren't making that diagnosis. We used a diagnosis called intermittent explosive disorder. That's a very good description of these kids who had emotional meltdowns.
Right.
Every once in a while, intermittent, they would have these explosive outbursts. The problem for providers, for clinicians, is that that diagnosis wasn't reimbursed by insurance companies. It was somewhere else in the DSM, and it wasn't a reimbursable diagnosis.
Right.
But in the middle 90s, a group of what really, really good, these are world-class psychiatrists, one group at Harvard and one group at Washington University in St. Louis, said, you know, these kids almost look like they're going through a manic episode, you know, so why don't we just let's just call it bipolar disorder. It was almost by accident, okay? They said, we know we shouldn't do this. We're not really making the diagnosis in children, but let's do that. When those codes were sent to the insurance companies reimbursed.
Mm-hmm.
So guess what happened? We stopped using, and I was in a place where we were seeing children using the diagnosis of intermittent explosive disorder. We stopped using that.
Right.
And we switched to bipolar disorder. Now we got insurance reimbursements.
Right.
That's another reason. And I'm not blaming anybody. There's nothing bad or untoward about this. It's just that these are the reasons why diagnoses can change, because now the insurance companies will reimburse for bipolar disorder, but not for intermittent explosive disorder. So guess what? You change the diagnosis.
Absolutely. And you're right. You know, we're not blaming anybody, and we're not saying that it's a big problem. The issue was that, and I get where, you know, you try to understand where the insurance companies are coming from.
Yeah.
Intermittent explosive disorder, sometimes it's diagnosing kids with normal temper tantrums. And it's like, okay, now kids that tended to be diagnosed later with bipolar disorder were kids who were chronically irritable. They had a lot of mood dysregulation and all that kind of stuff. And so they were more serious, more significantly challenged than a kid with routine, typical temper tantrums. And so the insurance companies were like, we're not going to reimburse for temper
Temper tantrum, right?
that's
Right.
silly.
I don't blame them. There's not,
Right.
I'm not blaming them. No.
So it made sense to call it bipolar disorder, and and it stayed that way for years.
Right.
Because it wasn't until 2013 when the
That's right.
DSM-5 came
Mhm.
out, and they
Right.
included, over the course of the previous few years, they started doing a lot of research on emotional dysregulation in kids, and they came up with this new diagnosis of disruptive mood dysregulation disorder.
Bernie, I didn't even think about that, but you're right. That was 18 years.
Yeah.
From 95 to 2013, we used this child onset bipolar disorder or pediatric. That was a 13-year period. I hadn't thought about that. Or 18-year period.
Yeah. So it was happening for a while. And of course there were a lot of psychiatrists, a lot of clinicians that disagreed with calling it bipolar
Mm.
disorder. And most of us that even did call it bipolar disorder didn't really like it. It was
Right.
just that was the best thing that we had at the time.
Right.
It certainly wasn't ADHD. It certainly wasn't,
Yeah. Hmm.
anxiety, really. It was something more substantial. And
Hmm.
it wasn't until 2013 that we got this new diagnosis. And,
Right.
you know, certainly if we look at a lot of the data, after 2013, a lot of those, a lot of diagnoses of early onset bipolar disorder in kids significantly dropped.
Because we
And
had another diagnosis.
something that was
Right.
better explaining it. Yeah.
Right. Right. So now what we used to call, well, not everybody, there's not uniformity here. There's not, there, people don't agree yet. In 2013, with the publication of DSM-5, we now have DM, disruptive mood dysregulation disorder, which is sort of a better description of these children. But we still see bipolar disorder being used. So now you see both diagnoses being used. So that's another reason, the final reason why they have increased. The increases themselves are substantial. I
Right.
mean, and these are the numbers. So with adults, 45% are more likely to leave with a
Hospital.
diagnosis between 1996 and 2010. It's 45%. There's been a 123% increase in adolescents. But the most alarming number is that in children from ages 5 to 13, there's been a 326% increase in the diagnosis of bipolar disorder in young children.
Right. And those are numbers, again, like you said, between 1996 and 2010 from patients admitted into psychiatric hospitals.
Right.
Um,
Mhm.
and so if a person was admitted into a hospital during that time, like I said earlier about, it's very easy to be Baker acted, and that's being
Right.
admitted into a psychiatric hospital. Uh,
Mhm.
if you were a kid or a teenager, there was a significant likelihood that you would leave with a diagnosis of bipolar disorder.
Right.
Um,
Mhm.
so we look at this and we see these increases. We see some of these prevalency numbers. Um, whether it's bipolar disorder, we could go through a number of diagnoses and
Right.
talk about it the same way. Um, there are some issues that have led to these significant increases in prevalence. And I think one of the first one is that, as you gave that example of the resident, sometimes clinicians just don't take enough time.
Right. If
Now,
they're pressured, right.
I think a lot of times that's because of insurance companies, because when you see after you see a patient the first time, you have to give a diagnosis if you want the insurance company to reimburse you. So you have to give a diagnosis.
Right. Mhm.
And sometimes you don't know after the first visit.
That's right. And when we talk about why the increase, and I look at these five possible explanations, I would never begin by criticizing others. I mean, this is difficult work that everybody's doing. So it's easy to be critical, but that doesn't solve anybody's problem. We have a healthcare system. The healthcare system we have is the healthcare system we have to use. And if you want to get reimbursed, I mean, somebody has to pay for your time. If you want to get reimbursed, you have to you have to give the companies what they want. If I have a person who comes in here and they end up without a diagnosis, the insurance company probably isn't going to pay for it. Okay. So, yes, you're right. After one visit, now you get a lot more information in 60 minutes than you do in 15 minutes.
Sure.
But most companies, medical companies, don't want you to see just 8 patients a day. They want you to see 40 patients a day because that's what pays the bill. So the system is structured in such a way that it forces us to spend less and less time with patients. And as you reduce the amount of time you increase the chance of getting a false positive.
Right. Yeah.
Okay.
I think another significant problem is, as we have talked about recently, is that, patients are coming in self-diagnosing.
That's right. Mm-hmm.
There have can't even tell you the number of times where a patient will come in and just start reciting almost as though they've memorized the criteria from a website. And they're talking about, well, yes, I have this symptom, this symptom. And, you know, I remember one person in particular, you go in and you type in a couple of words in the Google search, and the words that the parent shared with us is exactly the words that were on that website.
Yeah.
And, so again, you have to take enough time to be able to weed through that. But
Mm-hmm.
people are coming in self-diagnosing, and it makes it even more difficult to make sure that you have the right diagnosis, because they are saying the things that one needs to say to get that diagnosis.
That's right. Yep. Yeah. So the problem of self-diagnosis is also contributing. Drug companies want to sell their drugs. I get that. They have medications that are effective in some cases, so they're contributing to it. Insurance companies we talked about. And the last thing is hammers and nails. If, and again, this is not meant as a criticism, but the prescription pad is the intervention.
Right.
I mean, try the medication. And we go back to the original story that we talked about with that young 10-year-old girl.
Yeah.
Once a diagnosis was made, then medication started rolling. Okay. And so the prescription pad becomes the intervention.
Yeah.
And it's not the way it should be, but that's part of our healthcare system.
Right. And just the very nature of the number of medications that were tried over the course of that year or so with
Right.
that patient
Mhm.
really tells you that the diagnosis was wrong. Because if you had the diagnosis right, you would have had the right medication, or, within a couple of attempts, maybe.
Yeah.
You wouldn't have tried 15 different medications in the course of a year, and still they are wrong.
That's
No,
right. It still wasn't treated. It was a long time before somebody finally clarified the diagnosis.
yeah.
Yeah.
So, all right. I think that's it for today. But this is
Mhm.
just another great example of, why getting the right diagnosis is so important. And we have to, when a person is experiencing something, they,
Mhm.
hopefully be able to see a professional who can help weed through some of those issues and help them find what's really going on and make some
Right.
positive change in their life. So,
Right.
um,
Mhm.
this bipolar disorder is just another example of that. So, all
Mhm.
right. Well, that's it for today. Until next time, stay happy, stay healthy, and forget to be afraid.